Wanted to welcome you all to the FSHP Medication Safety Forum CE webinar tonight on second victims. Our presenter this evening is Carrie Diudo. Carrie is the Medication Safety Coordinator for the East and Polk region of Baycare in Tampa. She covers 8 facilities. She received her Doctor of Pharmacy degree from Hudson University in 2015. She completed a PGY1 at Eastern Maine Medical Center and completed a PGY2 in Med Safety at the University of Kentucky. Carrie is a preceptor for first and second year residents at the Baycare Health System. She's involved in med use safety process improvements, event review, and implementation of ISMP best practices across the health system. She focuses on trends in events internally as well as looking at nationally to see where systems can be improved to ensure safer practices. So very excited to turn it over to Carrie.
Thank you for the introduction, and thank you everyone for attending. I know it's really hard on a Tuesday evening, but hopefully this next hour will kind of either open your eyes to the topic or help dive in a little bit further to the topic if you've already heard of this. So we're going to be discussing second victim. And I just want to say a special thank you. So I had a PGY2 ambulatory care resident, Renelle, who was able to help me work on this presentation and really facilitate a lot of the dive into the studies. So this is supported by FSHP Med Safety Council. And so just remember to fill out your CE form, and anyone who attends the webinar will have to fill out, use the link to fill out the evaluation to obtain CE. If you have any questions, please contact Tamika. So starting, we'll go over the objectives. We have 3 main objectives tonight. So to review second victim background, evaluate current second victim evidence, and then identify ways to overcome second victim. So starting with a knowledge checkpoint, what is second victim? Is it A, the non-offender in a motor vehicle accident? B, a healthcare worker or healthcare provider who experiences significant emotional distress following an adverse patient event? C, the family of a patient who experienced an adverse event? Or D, your animals who are unable to care for after an adverse event? All right, so I'm seeing a lot of responses come in. I'm interestingly seeing a lot of B's, which is actually correct. But I did see a couple C's, so I want to make sure that I kind of explain this and help dive into why B is the correct answer. You'll see in a couple slides after the background kind of why it's denoted that it's the healthcare provider and not the family of a patient. So the background, I want to be able to go over, so there are different types of victims. So essentially, the patient and family would be denoted as a first victim, not necessarily the second victim. So the second victim would be the healthcare professional, and then the third would be the hospital system, and then the fourth would be the patient's harm subsequently. So as I said, the second victim syndrome really is around healthcare providers. So ultimately, the notion of second victim syndrome was defined in 2000. What weirdly came about it is it was more of a traumatic event that was defined as, but then 9 years later in 2009, it was deemed that the second victim syndrome was more applicable and it was defined as a healthcare provider specifically. So it took 9 years to denote and define from what they thought was a second victim that it was essentially a healthcare provider and worker. With that, it also took away the trauma aspect. So I find that very interesting. There is also things called second or trauma syndrome. And I think a lot of people combine second victim syndrome with the trauma associated from adverse events. So this is very different and something that literature is trying to decipher and kind of fill in the blanks to show you why second victim syndrome stands alone and is no longer deemed a trauma, because it's not necessarily a diagnosis that needs to be obtained to define what it is, but more of a feeling and emotion that can lead to downward spirals and or progression of potentially, as you'll see later in the presentation, leaving the industry. So this is a terminology we use as the healthcare setting, and it surrounds, like we said, the healthcare professional. And therefore, it did get denoted from that as to the second victim syndrome. And like I said, it was not a new term, so it was introduced in 2000, and then it became defined officially in 2009. And interestingly enough, I think the first publication that we started seeing, or the first study, was in 2015. So it took a while for people to really understand and want to realize that this was something that is occurring in our day-to-day operations, and our team members are affected by it. So it's nice to see people talking about this a lot more. So the background is healthcare providers who are involved in an unintentional adverse patient event in a medical error and or patient-related injury, and become victimized in the sense that a provider is traumatized by the event. And like I said, is the traumatized world, and trauma was taken away from that when the healthcare providers were put into that, which is nice to see that it's. And frequently, these individuals feel personally responsible for the patient outcomes. Many feel as though they have failed the patient, second guessing their clinical skills and knowledge base. The other thing that you see is that this can also come from a harm to a patient, but it can also be seen, what you'll see in some of the studies that we talk about, is it doesn't necessarily deem to have to come from harm to a patient, just an adverse event. So I think a lot of people denote a second victim syndrome as to a harm or death by a patient, but it can happen in any stages of an adverse event. And like we said, it could happen to anyone involved in direct patient care. But the leading cause is medication errors, which is why pharmacy is such impacted in this. I think there's also a lack of discussion of how pharmacists can be impacted in this. I do think that there's an uptick of discussion. I was just talking to a couple other pharmacists earlier in this week about it, and we're working on a manuscript for it. But truly, pharmacy rhetoric is lacking in the support of second victim syndrome. And a lot of the institutions focus on nursing and physicians and not necessarily pharmacy. So we're trying to get it out there. I will say AJHP just had on their podcast a really big discussion about it. So kudos to them for kind of bringing this to the forefront of pharmacists who are involved in this. So this kind of takes me back, is who can be a second victim? A, nurses; B, nurse practitioners; C, pharmacists; and D, physicians. Perfect. So it is E, it's all the above. Like I just said, it's healthcare professionals. It denotes between nurses, nurse practitioners, pharmacists, physicians. It can even be patient care techs, pharmacy techs. It can be anyone within the healthcare provided to a patient. So medication errors. So this is any preventable event that may cause or lead to an inappropriate medication use or patient harm while the medication is in control of the healthcare professional, patient, or consumer. So that's defined by NCC MERP. And then the WHO organization recognizes that patient safety incidences are often due to the complexity of poor design and operations of systems, and may occur throughout the entire medication use safety system. So patient safety indicates have shown to be linked to flaws in systematic, strategic, and organizational conditions. This is seen to be measured far from a healthcare professional engaged in the incidences and direct control. So I think the biggest thing with us is doing the just culture and ensuring just culture is associated with the medication error, and when we're doing the root cause analysis. Healthcare systems are constantly improving outcomes and working consistently on improving patient safety incidences. Ultimately, potentially causing second victims. So we're trying to work on these patient safety incidences so that we can prevent these second victims, but these incidences are currently happening. So there could be, and most likely are, people who are involved with second victim syndrome. So it should be noted that these are rarely a result of a single error or an individual. It can be explained through the Swiss cheese model. So this showcases all the failures and the multiple failures it has to go through in the multiple systems that we have set up. As everyone's probably familiar with from the safety models, the Swiss cheese model is how it obtains or gets to the patient. So again, it's rarely a result of the individual. However, that individual can feel a big impact by the event that they had involvement with. So like I said, potential second victims, the typical and atypical. So the typical ones that everybody thinks of, and this is all denoted on what is deemed in the literature and what is discussed at a lot of the supportive institutions that have programs, is the nurses, MAs, nurse practitioners, PAs, and physicians. And then you have the atypical ones. You have the optometrists, hygienists, dentists, and then you have pharmacists and pharmacy technicians. So I think that's something that we're trying to bring to light, as pharmacists are really involved in direct patient care, and we really have an impact on a lot of the events that occur. And we take it personally, and also we take our work as a professional and part of the care team very seriously. So this is where the impact is the biggest. So let's dive into the current evidence. I will denote that the current evidence came out before. There was a couple, I think there was one different study that just came out from MD Anderson, I think earlier, I think it was last month, March. And so I can kind of touch on that also if people are interested or have heard about it. But this is the current evidence before the presentation was submitted. So with that said, we have the impacts of second victims prevalence after an event ranges from about 10 to 50%. So almost 50% of healthcare providers experience impacts at least once in their career. And again, once you've experienced it once doesn't mean it can't happen again. But these impacts are over events that they recall and they think about heavily, and they have a big burden on their career. Sometimes people can't even get past the event, so it halts them into their ability to their next step of what they want to go into. So stunting their career growth, preventing them from trying to move into whether it's like a critical care area versus an internal med versus an ED department, and then sometimes move into a different kind of component of pharmacy. But like I said, according to a study, only 67% of healthcare providers are willing to seek support after involvement in a medical error. So, really, how an organization reacts and manages these events is really how these victims respond. They just actually came out in the MD Anderson study saying that the crucial time period is 24 to 48 hours. I thought that was really big to denote, is that somebody who hasn't been reached out to in that time period is really going to have a harder time recovering from the second victim syndrome and could experience a lot worse outcomes. I know I always think in my head, I like to watch a lot of crime shows and stuff, but they always talk about the first 48 hours as being the most crucial. But it's something we really need to think about with the second victim syndrome as well. And then, according to another study, negative emotions are reported at the way organizations manage the events, in which they can cause, even like I said, a greater impact or deterrent. So, second victim syndrome may be greatly underestimated, and we really need to figure out how we can mitigate this and help support our team members who are potentially, or as we know, 50% may go through this in their career. So we have the short-term acute stress, and this usually is more of that panic, shock, anxiety, guilt, shame, self-doubt. You kind of are second guessing everything. But then we go into the longer term ones that we see that manifest over the lack of getting the support. So it's more of a PTSD, such they think about it. So in the AJHP podcast, one of the pharmacists actually spoke about a past experience and what was really eye-opening to me is it had been 25 years since the event, and she still can recall almost every single detail and gets emotional about it still to this day. So I think a lot of people don't all who haven't experienced this, or maybe those who have, really can relate to that, or maybe are unable to relate to it, but it can be something that causes even functional impairment. One major point that a lot of the studies have said is if this isn't treated appropriately, or um, advice or counseling hasn't been seeked out, or somebody to talk to, you really can cause a bigger potential error by having essentially this self doubt or lack of ability to function as the pharmacist that you may once think or are. So, with that, we have stages. So, we have an article that reviewed 31 victims. They identified that there's 6 stages outlined for the recovery trajectory of second victim phenomenon. So the first stage is the chaos and accident response. So this then the victim is really distracted. So like I said, this is the first part where the victim, oh, I don't know why it's glitching. The victim is really distracted, thinking about the case, can't stop self-reflecting, trying to manage the patient themselves, their emotions, their reaction, and that's when they can probably make the most dangerous response or potential error after this event. The second stage is the intrusive reflections, and that's where they reevaluate the situation, saying the what ifs, what do I do now? What if I would have done this? How would I prevent this? Is how I could have prevented it. And then you kind of go into the stage 3, restoring personal integrity. So this is when they finally are seeking out support. Sometimes this happens in a couple days, couple hours, sometimes a couple weeks or months. So they are looking for an individual who they can trust, a trusting relationship, usually a colleague, supervisor, friend, or family. And this is one of the biggest challenges, was getting through to personal reflections of what will others think of me? Will I ever be trusted again? And so second victims described an inability to move forward when the event was followed by a non-supportive, negative departmental, potential grapevine gossip, which triggered more memories and more self-doubt, and essentially the lack of clinical confidence by themselves and their team. So the extent of this phase may be well anchored within the department's teamwork culture. And then you go into stage 4. So in enduring the inquisition. So after the initial focus on stabilizing the patient and the personal reflections, there's then that awakening that the institution will be reacting to the event in some way, and they don't know how. They don't know if it's litigation, if it's against themselves, against the team, against the patient suing, or specifically wondering if their jobs are at jeopardy. So then they get concerned of who I just talked to and disclosed all my emotions. Am I going to be in trouble? Am I going to? So it all depends on how your institution handles a just culture and tackles these. Essentially, this is usually, I feel like, when the RCAs come out. And I know some RCAs develop those processes or reflections with interrogating or interviewing the individual who was involved, but sometimes we're not necessarily seeing how they're doing, but more trying to figure out the solution and the root cause of the issue, as opposed to thinking about them going through these stages. Then we have the stage 5, obtaining emotional first aid. So they tend to seek emotional support in a variety of ways. Many express concerns about not knowing who's safe and who they can confide in. So then they kind of shut down potentially, and or seek counsel outside, so therapy or some kind of aspect, if they go in a positive direction with this. Sometimes people get nervous and kind of shut down and don't speak about it. And then you have a stage 6. So this is the biggest stage, that's the determinant on how they're able to either resolve and move on with life, or how it can really deter things for them. So they call it the moving on stage, but it's moving on in 3 different components: either dropping out, surviving, or thriving. So this stage is unique for recovery as its potential 3 paths. Dropping out is involving changing professional roles, leaving the profession, moving in a different place, location, organization. Um, Perhaps the intensity of the like haunted reenactments that drive the victims to second guess their professional inabilities and essentially drop out of the profession. But you have the other possible conclusion of moving on is surviving. So that means the individual performs at the expected performance level and is doing what they say is quote unquote okay, and they continue to be plagued by the event. So they're doing okay, and their peers see that they're okay, but really mentally they're still reliving and trying to move on mentally, but can't figure out how to. And um, then you have the last one, which is thriving. So this would be the most positive one. And this is those who are able to make something good out of it and come from the unfortunate event. So as I said, the ones that may be thriving, it may be take as the individual who spoke for HHP 25 years to start thriving and create these programs at MD Anderson and everything. That's what we like to see as the success story, but a lot of that deems on how the support is provided to them post event. So here's a real life pharmacy story. About 2 years ago, while transcribing an order, I made a single incorrect keystroke on my keyboard, and a patient's anticoagulation was held instead of being restored. The patient went on to develop an extensive arterial thrombus and eventually led to their death. Since that day, I've journeyed through the experience. I've eventually come to known as second victim syndrome. So I do think some of our pharmacists don't even know what this is and aren't sure how to process, or that they can even reach out, or that this is even a thing to be able to um, look into. But this is a story actually from an ISMP in 2017 safety bulletin that really explains how a medical error in the patient outcome impacted theirs. So here's a couple of the words and how they made it through their next phases, because it kind of puts into real life the different phases of second victim syndrome for somebody who has experienced this. So, stage one, the chaos and accident response, the pharmacist was flooded with thoughts and emotions. He could hardly identify. He felt emotions of sadness, anxiety, scared of being sued, and lonely. Couldn't really understand why his emotions were out of control and was at a loss of what to do or say. And then in stage two, the intrusive reflections, he lost confidence in his ability to continue practicing, had self doubt, wasn't sure if he should continue working, and decline the hospital employee assistant program for fear that he was scared it would come back for him. So he felt scared of everything in ways that he couldn't make sense. Some days they were able to breathe through the emotions, but other days it was difficult and would stay home and call out for PTO, which is really sad to see that people are impacted in this severity, but it's reality of the nature of these. So stage three, restoring personal integrity. They attempted to seek help and connect with colleagues who had similar experiences. This helps combat the loneliness feeling, but as a result, they pharmacists connected with a friend who worked through their emotions using art and paint, given the loss of words and actions that they were able to put towards it. And then they had stage four, they were enduring the Inquisition. So pharmacists moved on to eventually feel the flood of emotions dissipate slowly. The sadness became more periodic rather than constant. The pharmacist no longer felt scared, but was constantly reluctant to take any risks or remained very cautious as a practitioner. Their frustration shifted towards the unpredictability of their actions and the length of time it would take to improve um, and see their actions feeling confident again. And then in the final two stages, so the emotional first aid, the pharmacist finally started to see a social counselor and realized their feelings were normal, and with a consistent effort in improving, they were able to identify the feelings as grief, which began a slow and lengthy process of overcoming these emotions. This process couldn't be rushed and was very unpredictable for them. And then the moving on. So it took a whole year where the pharmacist is approaching the feelings of normalcy. They began experiencing glimpses of happiness and joy, which was more frequent. And looking forward, 2 years after the incident, they admit that their reduced ability to hold back emotions finally able to embrace the new reality. So it took this individual 2 years to overcome this. And I would say that as I've been hearing more and more stories, I think 2 years could be seem very long, but as I denoted, is some people are still 25 years out, really having a lot of these emotions. So as we've seen with these steps, there's numerous aspects that require a tremendous amount of mental processing, support from an employer and support team, continuous efforts of improvement and time. So this combination is imperative for second victims to truly overcome the impact surrounding their errors. And I think it really says a lot. It took me, I think, probably reading at least 6 different incidences that I was shocked at how long this process is, and it's unpredictable based on the individual. But the imperative support initially is what helps them get over sooner and quicker and faster. So, barriers to seek support. I think this is something that we've heard about with all of the different stages and phases, but I think that the biggest one that we can impact as pharmacists and anyone who's within a pharmacy leadership, even if you're not part of leadership, you can bring this forth to your leadership. But the inadequate organizational safety culture, I think it's not just the just culture, but we don't have the support of who's contacting that individual. We have the voluntary reporting systems at a lot of institutions, if not all of them, but are we having that follow through with the individual who could be impacted, whether it's from our department or others departments? How does that program look? Are we equipped to ask and reach out to those individuals if they're okay, and do they feel comfortable speaking to it and saying how they truly feel? I think a big thing is the stigma associated with the reaching out for help. I think hopefully talking about this and bringing this forth is helping to minimize that stigma. The fear, loss of professional respect and income, people dependent on their jobs and their families are dependent on that. Also, time off work. If they don't have PTO, do they have time to recover? Is there an opportunity for them to recover if they need that? Doubts about confidentiality in regards to this, and then lack of support of our contracted employees. Which bears us into the 5 rights for second victims that can be referred to as trust. So T is treatment is just. So victims should take on victims who should take on 100% accountability as their errors, but they need to know truly that it rarely is an individual error. It's either a systematic error or a multifaceted process breakdown error, and we really need to focus on that just culture. Ultimately, the primary concern is addressing the concern head on in any collateral damage that may have resulted. R is respect. So all members are susceptible to errors. The practice, the golden rule, treat others as you'd want to be treated, and also consistently lead by confidence and make sure that everybody is supported in an appropriate manner. You understanding and compassion. So the error can be detrimental to someone's confidence. So this is really big on the time and the help needed to grieve. And one must understand that the system carries numerous flaws. While ever evolving, it failed the patient. And then the second victim should be addressed similarly as the patient would be. They too are suffering from these consequences related to this error. S is supportive care. So psychological supportive care are methods that need to be implemented to prevent future damage or total loss of the second victims. There's an increased report, which is really sad to report out. I think I haven't seen the publication yet, but I've heard somebody talking about it. But there's an increased number in suicides associated now with second victim syndrome, which really breaks my heart to hear that this is something that we aren't talking about as much. I'm glad to see that it is being spoken about more, but we really need to be there to recognize that this is in the reality of our team members, and they're passionate about what they do and take to heart what happened. So we really need to make sure we have supportive care options for these individuals, whether it's reaching out, counseling, or anything like we've said. And then T for transparency and opportunity to continue. So this allows second victims to be open and honest when errors occur. It also promotes a better reporting of errors, which in turn then would aid into improving our systematic flaws. There should be no judgment when it comes to patient care. Again, we're all human. to err is human was the original med safety article that came out. So the system is filled with flaws, and anyone can suffer from second victim syndrome, and judgment should have really no place with any of this. So diving into our first study. Don't be overwhelmed by this. I'll step you through it. But I do love the graphics and it kind of helps hone in on it. So this study is titled Learn from Errors. So it's a post-traumatic growth among second victims, and it was conducted at a tertiary hospital in China. It was a descriptive cross-sectional study designed with cluster sampling that included 474 victims through the completion of an online survey to assess various factors related to second victim experience. So the objective was to explore the levels and determine the post-traumatic growth applying to the stress process model that they have. So this model is structured around three core elements. It's the stressors, the mediators, and the outcomes. So stressors are defined as initiating events, in this case, the patient safety incidents. You'll see how after the incident, there are multiple potential routes that led to these mediators, whereas the mediators are defined and described as those that influence the stress response. So in this case, coping styles, positive or negative, perceived threat, social support, measure using second victim experience, tools that will be covered in later slides. So there is a big supportive tool called SVEST, and we'll talk about it in the slides to come. And then lastly is that outcome representation and the consequences of stress, implementation of mediators for the study, and those of post-traumatic growth, meaning the overcoming of the event, which was associated with using the Chinese post-traumatic growth inventory. So I think this is one of the first studies that kind of looked at the outcomes of traumatic growth from second victims. So then next up is another article titled Addressing the Second Victim Phenomenon Among Community Pharmacists and the Impact of on Clinical Pharmacy Practices. So this is aimed to investigate the second victim phenomenon in community pharmacists, and it focused on the triggers, impacts on pharmacist well-being, and effects on pharmaceutical care and safety. It's stratified across 27 Sarabian community pharmacists into three nominal groups, so 9 participants each. Inclusion criteria included 5 years or more of experience in the community pharmacy and direct experience with second victim syndrome within the last 5 years. What this study found was the most significant trigger for second victim syndrome appeared to be inadequate counseling and incorrect drug dispensing. So the errors associated with those two is what caused these errors. And based on that led to these pharmacists having second victim syndrome. So considering all the incidences, the wrong dose dispensed was accounted for 44% in this study, and near misses and no harm events were accounted for 33%, and serious consequences were accounted for 26%. One of the biggest phenomenons actually with the MD Anderson study is that of their 3 top ranked errors that were associated with second victim syndrome, which kind of is in a line with this one, is not necessarily an as we said, the serious consequences for this study accounted for only 26% of all of the doses dispensed. The major errors that reached the patient but didn't cause harm was the number one set of second victim syndrome. So take that in, and I'll repeat it one more time because I think it's very interesting and very prominent that we discuss that second victim syndrome is not always associated with harm to a patient. It is an error or an adverse event that happens. It reaches the patient, but it may not be harm to the patient. They're still going to, in potential, to have a association with second victim syndrome. They could feel that they should have prevented it. Luckily, it didn't cause harm. I think the ones that take longer for recovery are the ones associated with the harm to the patient. So we need to make sure that people feel open and honest about reporting these events and that we're looking into it, but thinking even if the event was a good or bad outcome for the patient, that we're reaching back out to those pharmacists. So here we have a summary of the final rankings, and to your left, you'll see the incidents threatening patient safety, and to your right, you'll see both the supporters in incident situation and mental, physical, job-related outcomes. This is not all-inclusive list, but it just showcases the highest rankings from the participants that they submitted. So the study conducted that second victim may be likely linked to breaches in fundamental practice standards that may impact the quality and safety of pharmaceutical care interventions and then leading to the pharmacist's well-being. So there are a lot of things that play in factor of there's not one definitive root cause analysis that seems to be leading to second victim syndrome, but all of these that can cause those adverse events that can lead to somebody feeling that. So then how do we overcome it? So we just talked about all the like a few studies that show second victim syndrome, and we talked about all the different stages and how people are affected by it. But then how do we overcome it and what do we do to mitigate it? I'm sure a lot of people are looking forward to this section of it. So knowledge checkpoint. Are there programs for second victims? True or false? I guess I can also open up into the chat too if people want to open this part up is do you have a second victim program at your site currently? So I'm happy to see and also sad to see, but I do see that people are saying false, but the answer is true. And I'm glad those who are here that are saying false are here because I'm hoping I can open your eyes to see that there are programs for it. There may not be a program at your site, but maybe you'll be the one to be able to bring this back. Feel free to reach out to me if you have any questions. I would love to be able to help kind of put you in contact with people who have done it and who are going forward with it. But I do think this is a huge outreach and potential that institutions can move forward with. So leading into the EARNEST. So EARNEST is a European Cooperation in Science and Technology Association. So this was established in 2020. It serves as a collaborative platform that incorporates international and diverse disciplines and perspectives, including legal, educational, professional, and socioeconomic considerations. The primary objective is to facilitate an open and comprehensive dialogue among stakeholders and considering the implications of second victim syndrome. So this was great. I thought the policy contains actionable strategies aimed to minimize the repercussions of second victim phenomena while simultaneously supporting the patient safety. Overall, the policy statement components include ensuring patient safety is a global priority, ensuring the healthcare provider capacity is a priority, allocating resources in second victim support, rethinking legal framework and building a just culture, and then the earnest commitment to successful actions and outcomes. I've included this, it's called The Vicious Cycle of Loss of Quality and Well-Being as shared in this article for your reference. You see how many of these events that increase the emotional impact of healthcare workers and the team, and depending on the degree of support, team members can either thrive and escape the vicious cycle, and this would be the ideal scenario that we would want with this proper support and coordination. But in other circumstances, the non-ideal scenarios include entering survival mode where the patient care quality changes and the dysfunctional coping mechanisms are adopted. Members do sometimes end up leaving the organization, like we said, and altogether, they can even leave the profession totally, but more pressure on other team members from having this emotional support and seeing the lack of support for that individual causes a cycle to the department as well as to the individual. So like I said, there is a tool that is out there that a lot of people utilize. It's called SVEST, so it's Second Victim Experience and Support Tool. So this is a tool that's actually validated, and it has an original model that was a 7-factor model. It was a 30-item survey, which assisted healthcare organizations to implement and track performance of these second victim support resources. It was conducted in a pediatric hospital treating children and had a total of 983 team members, including but not limited to nurses, physicians, pharmacists, medical technicians, were all invited to participate in this survey. And out of those final sample size, 281 that were analyzed, 8.5 were only pharmacists. So pharmacists didn't really, whether they didn't participate or didn't have big impacts on wanting to or knowing about this. So we were trying to still get the word out there, but ultimately we want to make sure that we're going over the different tools that you can use. So the final list then included the 7 dimension to measure second victim response and support characteristics. So 2 were additional related outcomes that frequently were cited in the literature that referred to the reactive art in more details. So you see the turnover intentions and the absentees. And so these were then reflected on. It was a 5-point measure, Likert scale that was ranging between 1 being strongly disagree or strongly do not desire to 5 being strongly agree to strongly desire. Overall, the end goal of this and ended up being a collaborative responses that was a 25 item survey, and it was quicker and more intuitive for people to be able to take. So this was assessed, like I said, for validity and internal consistency. And in 2 ways, they did an initial survey where it was written in total 9 individuals before they even released it. They used 3 nurses, 3 physicians, and 3 pharmacists who were not part of the research team to validate the tool. And then the second was through the use of confirmatory factor analysis, which assessed the factorial structure of it. They changed things around. And like I said, it became a 25 item 7-factor model that resulted in the final survey. This survey then, like I included in this slide for reference, showcases the support options and how desired and undesired they were among participants. So I'd like to draw your attention to the first 2. A respected peer to discuss the details of what happened, and the discussion with my manager or supervisor about the incidents. These are the most desirable options. So 80.5% and 73.8% respectively. That's huge. I was really shocked to kind of see this be what people wanted for support and what was the most impactful support. So then we lead into some resources for second victims. A lot of times when you reach out with support, you want to be able to provide resources for them. So there's 4 different major resources that have right now, and I'll step you through them. There are more that are coming out as I believe the year is going on, so keep an eye open for that. But the biggest 4 we'll discuss. So the first one is, it's called For You. So this was developed by the University of Missouri Health, and the purpose was to provide one-on-one peer support to second victims within their health system. It had a 3-tier approach. So this is unique to them. Tier 1 was with the local emotional support from the manager, supervisor, fellow team member. And if further intervention were needed or assessed to be needed, they would move to tier 2. And this was available and provided support from a trained peer supporters and patient safety risk manager resources. So their patient safety team was trained in this. And then if an employee needed further support beyond tier 2, they would move to tier 3. Tier 3 is available and includes access to employee assistant program, a chaplain, a social worker, and a clinical psychiatrist. Psychologist. So they have a website that has helpful resources for anyone that's interested. And their key lesson, they said, in the importance of having a visible institutional commitment from the executive leadership to ensure reliable and organized support structure that was put in place to make sure it didn't fall off kind of track, making sure that people were following through with this and talking about it. And every time an error came up, they made sure to publicize this even more. Then the next one is RISE. So this was developed at Johns Hopkins, and it's Resilient in Stressful Events Program. That's what it stands for, RISE. This was actually, interestingly enough, developed in the pharmacy department, and it was first piloted there. And then once it took off, it was expanded to the rest of the hospital. So the program offers both one-on-one and group support options depending on the specific needs of the second victim. And they used a two-tier call system. So this was two multidisciplinary peer responders on call at any given time. So after the implementation of the program, a survey was assessed to assess the success of the program, and they found that 87.8% believed that the program met the second victim's expectations, while 82.5% were satisfied with the interaction, which I think is huge to see that peer to peer support and having an on call program really met the needs of their team. It should be noted, though, that most encounters are related to adverse events in this and not necessarily the medication errors. So this was opened up to, like I said, the whole hospital and health system, and not just those numbers are not just from the pharmacy department survey. And then the next one we have is You Matter. And this program is developed at Nationwide Children's Hospital. And like RISE, it started as a pilot in the pharmacy department before branching out to the rest of the hospital. This program is actually based on 5 pillars of support. The first pillar being the second victim peer support program. The program included and includes still to this day, more than 700 peer supporters from all disciplines within the hospital. And something to notice in all three of these is that they all provide training sessions and workshops for other hospitals. So if you see one that you like more or one that kind of relates to you or your institution better, you can reach out to those programs and they're more than willing to help you kind of pilot and start um, working on your own institutional program. But this one in particular, I think, deserves recognition. They've helped provided guidance to more than 35 hospitals in the nation on a support system for second victim syndrome. And then another last but not least kind of, but they're, like I said, AJHP is coming out with a lot more from their podcast and from their March 15th release. They actually talked about an editorial on opening the doors for second victims. So there are more areas that you can reach out to and see literature on this. But APHA is a really big resource. I don't think I even thought that they would have a second victim option, but they have some educational materials regarding second victim. They provide educational support groups monthly. They have monthly meetings with trained emotional support peers to facilitate these sessions. I think this is a fabulous resource for if you don't have anything within your hospitals and while you're trying to develop, knowing and being able to give this to a team member who needs this or somebody who may need extra support that you're not able to provide. These emotional support meetings monthly are really great. They're free of charge, conducted virtually, very confidential, but registration is involved. So there's the QR code if you need it. There's also the link on the bottom if you want to be able to connect to it easier. So with that, just kind of wrapping up anything, but many healthcare professions will experience this at least once in their career. And most people experience, unfortunately, this a couple times in their career. But we want to make sure that any errors that they experience don't lead to second victim syndrome, but recognizing that it may be something that could lead to second victim syndrome. Again, 50% of healthcare providers have, it's 10 to 50% have had second victim syndrome. And the support of the health system and peers is imperative for second victims to overcome these stressors. And there's really no clear guide and standard process to help these. As you've seen, we have many different institutions, many different studies who take different approaches. But I think the biggest one we can take away from here is having a manager or peer reach out in a timely fashion, as they said in the MD Anderson study, 24 to 48 hours is the critical time to have that connection. But victims can get help and implement resources at their workplace. We can aid in prevention tactics, making sure that we have a just culture and root cause analysis to prevent future error, and then help second victims overcome these obstacles. So here are my references. And then I always end with, so long as it involves humans, healthcare will never be free of errors, but it can be free of injury. And I mean by injury in this capacity, we can try to be free of making sure that our team members or our colleagues or our counterparts all have the ability to get the help and support that they need in regards to the second victim syndrome. So I say any questions, but I kind of want to open it up. I know I haven't really been able to ask, and I appreciate you all listening and tuning into everything. But in the chat, is everyone, if you're willing to, able to kind of denote, do you have a program that you're aware of? Is there one specifically for pharmacy, or is pharmacy involved in the hospital system that you're at? I see a couple no responses. Yeah, I see the pilot for nursing, so general wellness and nursing, but nothing formal for this and or support for pharmacy. Oh, I see a yes. That makes me so happy. Are there any
Carrie,
questions? Oops, sorry, go ahead.
oh no, sorry. I was gonna throw a question to you while people are
Yeah,
still putting it in the chat. You clearly have a big passion for this topic, and definitely thank you for leading out on this webinar for us this evening. Does Baycare have a formal program, or are you working on one?
actually, they don't. We have safety coaches, and I'm trying to work to see if we can get those trained as potential second victim syndrome. Like I said, it's still like a new topic, I think, coming to the forefront of healthcare in general. So I was trying to, I think I got a lot of, I joke, bites after my med safety CE. That was the 2 hour one for the Southwest branch of FSHP that I added it in. And I joke, I twisted Stacy's arm to add a little bit into the med safety CE at the annual meeting. But I think as we start talking about it, every health institution or every healthcare team has a different avenue of what works for them. So I'm not sure. I'm still trying to find the facet of, do we have it go within risk and quality like some people have, or do we have it within our own department? Again, like I said, Baycare luckily has safety coaches in all departments, so maybe the training at one of those would be helpful to have them as a peer to reach out initially, but that would mean that we would need to know when that error occurred and how to get that word back out. So it's kind of facilitating the connection between the error and the connection to the team member.
Yeah, thank you for sharing that. So at Advent Health, I'll just share because I'm off mute, but we do not have a formal program, but we are working on one. I mean, we have the employee assistance program, which includes free
Right.
counseling services. So that absolutely is still available. But we don't have a formal program at this point either. We do have a couple questions in the chat. There's one of, how does the facility error reporting system get involved?
So I think that's a really great question. So I think that's kind of how I was. It's a fine line on the confidentiality of, we want people to report and feel comfortable reporting almost anonymously, but then at the same time, how do we make sure that we reach out and support those individuals involved? I think that's where I'm kind of at a crossroad of how to present or approach this. I wish I had a great answer, and I think, like I said, reaching out to these um, health systems and making sure, I know we have managers, our managers at each site, pharmacy managers at least, review these events. So maybe working with them to follow back up. We don't have an anonymous reporting system. We have a reporting system that it actually says the individual who reported it. So using that name to kind of follow back up and support and show support. But whether it's from the manager capacity or the safety coach, I haven't figured out what we think is the best avenue. But I think that's how you would get the reporting system involved, is whoever's reviewing those kind of reporting out who needs or who they think might need that extra support.
I think that's a great point. The other thing that comes to my mind of just so outside of the error reporting program, but also just like how do we identify these individuals? But I think that's also if you have some of local, like your peers that are also trained. And so if you hear of anything or if you witness anything, then they can
Right.
also help identify those folks.
The other thing that was brought in that I haven't brought up in this conversation, but I think is in the forefront of a lot of people's minds is residents. I don't think we've thought about how residents, they're more prone to potential errors, especially they're early in their careers, they're learning their confidence, they don't want to look like they don't know what they're talking about. But how do we get them to kind of open up? They are at the more critical stage, initial stage of their careers. How do we ensure, like the one that the individual spoke at for AJHP, her error was as a resident, and that's what took 25 years to kind of figure out, and she took a whole different career path than she expected because of that. So what support do we provide those residents to feel comfortable to come forward, and then give them that emotional support through it? I think that's kind of the fine balance too.
I know there's
I
been
saw
some
oh,
questions. Well,
yeah.
there's been some questions in the chat about the handout. So I think
Oh,
I was messaging with Tamika earlier. We're gonna get a copy out to folks at after the session ends. So I'm glad there's a lot of excitement about the topic and wanting more information. So we will be sharing that.
I saw a question that said would be interesting incorporating and plan. Oh, it just moved, planning for this as a part of FMEA process. So yeah, I'm not sure. Like I said, I'm not sure what it would take to go into that and how we would be able to. But I think that would be working with your local facilities, working with your team resources or your HR, human resources to see what you're able to do and what facilitates and kind of is allowed. I think everyone's kind of unsure with where everyone is and how to handle this. I think everyone has a different path with second victim syndrome, but making sure that we take it seriously and provide whatever anyone needs, I think is really important for mental health support. Did I miss any other questions?
I think that is it. So I think
But
we can end.
yeah, I really appreciate everyone's time. And like I said, I saw Stacey say, like, I am really passionate about this, and I'm still in the same kind of, struggle as you guys, trying to figure out how we can make this go forward. I don't think it's an easy process. And I think a lot of these people who have been working towards this have done studies and proven and gotten the support. So I do think it's kind of leveraging that. What works and doesn't work and what your institution's willing and able to provide from a support standpoint. So my email's on the presentation. Feel free to reach out to me if there's any help that I can be or support to you or your facilities. Just let me know. That's what I'm here for.